All right. Assalamu alaikum wa rahmatullah. Good morning, everyone, and thanks for the organizer for their kind invitation. So, I will talk about the MSI and tumor mutation burden testing. This is my disclosure statement. And as we have seen this morning and also in other presentation yesterday, that MSI and tumor mutation burden are emerging biomarkers for the immunotherapies for good reason, for the predictive response of the treatment, but also as was Dr. Fuad telling, MSI is a common phenomenon that we see across many tumors. And I think to answer your question, Dr. Khalbas, about the breast, I'm not sure if I can see it, one of these, but the top one is the endometrial followed by the gastric. The endometrial is about 17% of the cancers that has MSI. Tumor mutation burden also recently started to emerge as across different cancers. This is a study published as a review a few months ago following 27 different tumors. And you see on the x-axis the median number of the coding somatic mutation. So the more you go to the right side, the higher number of mutations. On the y-axis, this is the objective response rate. So the higher it is, the better response for the patient. On the top right, this is the cutaneous squamous cell. So it has a lot of tumor mutations and at the same time, excellent response rate. And some of the tumors, like this one in the middle, do we have a pointer? Sure. So the Meckel cell, for example, here has a medium number of mutations in the tumor burden, and at the same time, it has an excellent response. So, and some of the other tumors will have a medium number of mutations, and yet it's not responding so well, like the small cell lung cancer. So there's a lot of spectrum in here. So this talk today, we will talk about three things. One is the molecular biology. Why this happening, the MSI and the tumor mutation burden. Then we will talk about how to detect them, and finally, how to incorporate them in our diagnostic workflow. So there are known immunotherapy targets, the BDL1, the B7, and I'm not going to talk about these, but the point here is these are known proteins. They are expressed normally and targeted by different therapies. And this is how normal proteins, this is a quick review of molecular biology. They are encoded in genes on the DNA level. They expressed RNA, showed the proteins, and they are expressed on the tumor cell. However, when we talk about MSI and tumor mutation burden, like Prof. Dael explained, we are talking about new antigens that's not normally part of the DNA. So it's a mutation that's happened randomly in the genome. And what will happen is this mutation will transcend to the RNA, then to the proteins, and finally it will give us a new antigen that will be captured by the immune system. The more mutation at the DNA level will transcend to more RNAs, and they will create even more proteins, mutated proteins, and more new antigens. So, and this is the basic idea behind both MSIs and tumor mutation burden. So that is at the cell level. What about the molecular level? When cells divide, they need to replicate the DNA. And one of the enzymes, the polymerases, called poly-EVE, is going to replicate all of these. And it is so fast, it can replicate or copy 1,000 nucleic acids per minute. But at the same time, it's not perfect. Sometimes it will introduce some errors. But it has an activity, a proofreading activity, that's when it's incorporating the wrong nucleic acids, it will have a proofreading that it will correct it to the right one. Sometimes, even with this proofreading, it's not perfect. Sometimes there are mutations that is missed by the polymerase. So we need another solution for this. And this is where the mismatch repair system that Dr. Fuad was describing comes into the picture. These are 4 different genes in a complex, that's the MSH2/6, MLH1, and BSM2. They will go and scan the DNA, looking for those mutations and fixing them. What happens when the polymerase itself is mutated? You can imagine that it will be sloppy. It will copy the DNA, but it will introduce a lot of errors because now it is missing the proofreading. In the same time, what if one of those components is mutated or absent? The same thing will happen. It will not be able to fix a lot of mutations. So you can see that either losing the proofreading or the mismatch repair system, among other mechanisms, will lead to hypermutated status in the tumor. And this is the end goal is how can we detect the new antigens? So I will skip through the papers because we have been describing the importance of these biomarkers and move to the detection methods. So the most common one is using the immunohistochemistry. And basically, we are trying to detect the expression by using antibodies on one of the proteins, the 4 proteins. If this gene, for example, PMS, is deleted or silenced, it will not produce RNA, and then no proteins, and there is no antibodies, and this is what we see in the immunohistochemistry slide. This is the table that will show how to combine these 4. I will not discuss it as Prof. Dial already covered this. But the second method is the BCR fragmented analysis. And it's targeting the microsatellites. Every one of us has more than 100,000 regions of these microsatellites. They are simply repetitive regions. Here, for example, we have a stretch of 12 Cs. But sometimes it could be dinucleotides like AT, AT, AT. Here are 6. Or triple nucleic acid, CGG, for example. And the polymerase that I was describing before, when it's copy this, and sometimes it have a slippage because it's so repetitive, sometimes it doesn't know if it is 6 Cs or 7 Cs. Normally, it will fix it, but when it's mutated, this is where we see when it's working, it will always copy the same number. When one of them is mutated or absent, then we will start to notice this phenomenon where we have additional Cs. And the way we detect this at the molecular level is we do fragment analysis. Basically, we want to see the size. So this is the normal, and you can see we see a lot of different fragments, different sizes. And this is how it tells us that this complex, the MSI, is not working properly. Prophet Dal already mentioned that we need at least 5 different microsatellite regions to decide if the mismatch repair system is working or not. And at each one, we are trying to see from a normal tissue compared to the tumor. And if we have 2, as he mentioned, or more, then we will call this MSI high. Now, the emerging third method is using next-generation sequencing. And it has the potential to do the sequencing of the gene itself. So we would know if there is a mutation in the full sequence, if it is deactivated or not. And this has been done for 5-7 years. It's not a new news. But in the last 3 years, we have seen papers that actually showed how next-generation sequencing can detect MSI directly from those microsatellites. And it also can detect the tumor mutation burden. So all the 3 really areas can be detected by NGS. But how good is it really, at least for the MSI part? So this is a study recently published this year comparing the fragment analysis compared to the next generation sequencing in all cancers and in the colorectal cancer. And you can see a fantastic correlation between the 2 methods. So it's really a very sensitive and specific method for the MSIs. But there is a big caveat here. If your lab is doing NGS on a panel that has been created or 3 or 4 years, probably it's not going to include MSI, nor it will be big enough to include, to read the tumor mutation burden. So a lot of companies nowadays are trying to repackage their NGS panels and tells us that, oh, it can detect MSI or it can detect tumor mutation burden. But how you judge this is simply by looking at two things. One, how big is the panel? And how big is not the genes, it's how big is the regions in nucleic acids. And one way to do it is by doing a large exome. Basically, we read all 20,000 genes. And this is common in the germline world, in the inherited disorders. And the size of it is usually 38 million bases. This is a fantastic way to detect tumor mutation burden. But for most clinical lab in cancer, we have much smaller panels that is usually less than 1 million bases. So if it is less than 1 million bases, probably it will not be sensitive enough. So the question always, if you want to make sure, are we good to detect tumor mutation burden, is asking, is our panel bigger than 1 million bases or less? And this is a comparison between the exome and the panel from Foundation Medicine, which is 300 genes and 1.1 million. And this shows a good correlation, 74. So how do we implement all of these technologies in the diagnostic workflow for the immunotherapies predictive biomarkers? So this is on the immunohistochemistry parts. As Dr. Adel mentioned, it's a part of the routine work. For the equivocal cases, we can use the PCR. And the NGS now is emerging as a technology that can do all of these three. And now the question is, what is the relationship between MSI and tumor mutation burden? Are they always both high, or the opposite relationship, or has no relation? So this study by Foundation Medicine is by far the largest study so far comparing these MSI and tumor mutation burden in 100,000 cancers. And the color is not, there is a light gray color here, the big circle that showed they sequenced more than 62,000 cancer where they have both MSI information and tumor mutation burden. And you can see that the blue color here is tumor mutation burden high. The gray, the dark gray is MSI high. And look at the overlap between them. So when the MSI high, it's usually associated with high tumor mutation burden, but not the other way around. So most of the cases that you see with tumor mutation high does not mean it will be MSI high too. And this is reflected across different cancers. So in the top here, the skin squamous carcinoma. And the blue color is tumor mutation burden high and MSI stable. So this is the highest. The next three ones are melanomas and skin cancers. And they don't show MSI. It's basically tumor mutation burden high. One of the strange cancers that show the opposite way is uterus endometrial adenocarcinoma. And you can see almost 25% of them will be tumor mutation low and MSI high. 2/3 of it will be MSI and tumor mutation burden high. So why I'm telling you all of this? If we add BDL to the picture, BDL is the green part. So when it is high, it does not mean it will be associated with high tumor mutation burden, nor with MSI. So all this means that we will be going through reports that will look like something like this, where we will have 5 axes for different IT immunotherapies, biomarkers like MSI, tumor mutation burden. We will have BDL1 on the sides, mutation, actionable mutation here, and emerging immunotherapy biomarker like CD8. And we will start to see patterns like for the melanoma, for example, we will see it's high, it will be high in the tumor mutation burden, and we'll see BRAF mutation. In the lung cancer, for example, we expect to see a pattern looks like this. And not all lung will look like this. Sometimes it will only show actionable mutation only. So we are trying to accumulate all this information in our reports and trying to merge something from the immunohistochemistry, in this side the BDL1 CD8, MSI from fragment analysis, and these two from NGS. And I think this is where we're going to see even more access as we move forward to more biomarkers in the immunotherapy. So in summary, these are, although they look different from outside or the molecular level, they are the proxy basically to the same thing. Do we see more new antigens in the tumors or not? And disturbance of molecular events or mechanism like proofreading or mismatch repairing will increase those new antigens. And we have currently 3 major clinical assays: the immunohistochemistry, the BCR, and the NGS. This one, and I expect in the next 2 years, will be enough for all of them, because we don't want to do multiple testing for the same patient if we can get it from one assay. And with that, I would like to acknowledge our pathology departments, the oncology team, and my technician in the molecular oncology lab. Thank you very much.